Everyone. My name is Don Wildfong. I'm the implementation facilitator with the Waterloo Wellington Older Adult Strategy, and we're delighted to welcome you to this, our first in our Knowledge Exchange series, focusing on what every healthcare and community service provider needs to know about the COVID-19 vaccination. So it started off as a beautiful sunny morning, and we're really pleased that you can be here with us today, as we're joined by some guests who will share what is so topical and on the minds of so many in society, as we all look so forward to the day when, of course, we reach herd immunity, but when we can all have our family and friends safely vaccinated against COVID-19. Today's session is being recorded. Please know that we can't see you if you're watching from home or as a participant. The only faces that will be recorded are those who are presenting. A recording will be shared following this event with you likely early next week. We have the opportunity to answer some questions if time allows later on in the presentation. So should you have any questions or comments you'd like to offer, please do use the question and answer section of the Zoom platform. I'll quickly mention that the Waterloo Wellington Older Adult Strategy was envisioned as a 10-year comprehensive plan to better support the aging of our population in our communities of Waterloo, Wellington, and to help strengthen the health system that supports them. So today we have a few objectives that we'll be talking about. So we'll learn more about how vaccines work and what vaccines are available in Canada and other vaccines on the horizon. We'll learn about the contraindications and precautions of these vaccines and the potential side effects, the rollout of the vaccines across the region, and who is eligible right now to receive the vaccines in each of our areas. So we'll have representation from both Wellington and Waterloo. So we're pleased to welcome 4 presenters who have been very busy engaging many groups around vaccine safety and in order to build vaccine confidence. So today we're joined by Dr. Kelly Grindrod, who is a pharmacist with the Ontario College of Pharmacists and a professor in pharmacy and innovation, an associate professor with the University of Waterloo School of Pharmacy. We also have a longtime friend of many, Dr. Nicole Didyk here. Dr. Didyk is a geriatrician and associate clinical professor at McMaster University. We have Fawzia Bag with us today, who is the Equity and Anti-Racism Advisor in the Equity, Inclusion, and Human Rights Unit of the Chief Administrator's Office at the Region of Waterloo. And Fawzia has been very involved in community engagement in Waterloo Region. And finally, not least but last, is Dr. Mishi Motomura, who is the IMS liaison for COVID-19 response with Wellington Dufferin Guelph Public Health Unit. So we'll move right into the presentations, and we'll start off with Dr. Grindrod, and I hope you'll enjoy this session.
Thank you. So this slide deck is part of a collaborative effort from a number of healthcare providers across Canada, including infectious disease physicians, family doctors, nurses, pharmacists, trying to put together information that helps people build confidence in the vaccine. Next slide. So there's 3 main things I want to review here, is just understanding how the different kinds of vaccines work, reviewing the ones that are approved in Canada, and any contraindications and precautions you should know about. Next slide. So this slide here, it's funny, I update it regularly. Sometimes there's a lot of moving parts in it. I don't always remember to update each part. But one thing I want you to note is in that far right corner, we have given over 5.5 million people for at least a first dose vaccine or doses administered in Canada. When I started doing this slide, you see I forgot to update on the left hand, but it's a good contrast. The 2 million was just March 13th. So we have had a huge number of doses given in the last month. It's incredible the pace with how things are picking up here. If you look along the different provinces there, you'll notice that a lot of provinces are over 500,000, approaching 1 million. In Ontario, we've given over 2 million doses. And if you look at the map here, when we started this, it was 2%, 3% of the population vaccinated, and it hung out there for a long time. Now it's getting up 8%, 9%, 10%. And we prioritized early on the northern communities in the Northwest Territories and the Yukon, and they're approaching over half the population vaccinated. Next slide. So let's go through what the vaccines are. The first is the mRNA vaccine, which is Pfizer or Moderna, are like most wanted posters that tell your body how to recognize COVID-19. They can't and won't change your DNA. Next slide. So if we start on the left-hand side here, the mRNA vaccine is injected into your body, but it cannot change your DNA. That's the most important thing to note. It cannot change. None of the vaccines that are approved can change your DNA. Your cells read the mRNA instructions and they start building the same kind of spike protein that COVID-19 has. So we don't inject the virus into the body, right? We inject instructions on how to build just a piece of the virus. It's really quite clever that they've done this. They've been doing a lot of research actually with this type of vaccine around cancer, Zika, HIV, all sorts of other ones. And so it's been really interesting the last several years. It's been hard to get these instructions. They're very fragile instructions into the body. So the big leaps that we've made recently are we wrap the instructions in this protective fatty layer, almost like a helmet around it, to keep it stable enough to get it into the body. It gets in the body, these instructions, tells the body how to make just a piece of something on the COVID virus, so on the surface called the spike protein, and then it's very fragile. It goes away, it dissolves. So once your body has made some of these spike proteins, so again, it's not the virus, once your body has made some of these spike proteins, your immune system can look at the spike protein and start building a defense and launch an attack. This is the point at which you might feel some fatigue, headaches, or a fever. It's totally normal. This is your immune system learning how to fight COVID. Your body can now recognize COVID-19 spike proteins and fight COVID-19 effectively. You're now immune. Next slide, please. So there's 2 mRNA vaccines approved in Canada right now. There's Pfizer and Moderna. Each have 2 doses. The Pfizer one is 0 and 21 days, so 0 and 3 weeks, and the Moderna is 0 and 28 days, or 0 and 4 weeks. Pfizer was researched in people aged 16 and up, and actually we just saw headlines yesterday that they're finishing their trials for 12 and up, which is great. So we're going to see it, hopefully being used by the summer in younger people. And Moderna is 18 and up, and we've had maybe about a week and a half, 2 weeks ago, news that Moderna had launched or was getting ready to launch its trial for ages 6 months and up. So the research is underway with children. Now, the thing to note here is that this is always raising some questions about this 4-month delay for the second dose. The reason 21 and 28 days were chosen was not because that's the best time to give a second dose, but because that was the fastest way to get 2 doses into people to speed up those trials in a pandemic where we desperately needed vaccines. So what's happening now in real time, science in real time, is they're trying to figure out what is the best time to give that second dose. It may actually not be 21 days, it may be later, but for some populations, it might be 21 days. And so I think what we're going to see in the next few months is the instructions around, okay, give your first dose, second dose, delay the second dose in this group. Oh no, wait, let's give the second dose earlier in older people. All that stuff is going to be constantly changing. Don't be surprised. Prepare to be a little bit flexible with second doses. Next slide. So how effective are the mRNA COVID vaccines? So a lot of us know this already. Pfizer and Moderna are 95% effective, give or take. This is incredible. So this is effective against any symptoms of the illness. And we're seeing headlines, for example, this morning I was reading stories on how in there's a couple of long-term care sites where people who are fully vaccinated, 2 doses, test positive. But what's really remarkable about those stories is that if you actually read them, the people are asymptomatic testing positive, and it's not spreading throughout the home. So when we look at 95% protection, what that means is still there's 5% of people who are going to get COVID. But based on what we're hoping will happen, based on these news reports that are coming out, they may get it, but they may be asymptomatic or have very mild infections. That's what that 5% who aren't fully protected, we're hoping will end up having. And that's actually the case for most vaccines. And these vaccines seem to be great across ages. Now, no, next slide, please, thanks. So there's a good study that's come out of come out of Israel with the Pfizer vaccine. Israel's well ahead of the rest of the world, as many of you are aware. So at 2 to 3 weeks after the first dose, in this group that they studied in Israel. About half of people are protected against an asymptomatic infection, so testing positive but no symptoms, and symptomatic illness, so testing positive with symptoms. But also, what we really care about in this pandemic is hospitalization, severe illness, and death. So when we've had coronaviruses for years and they cause bad colds, and so there's bad cold season. What's happened with this particular coronavirus is it causes severe illness, hospitalization, and death much more than other respiratory conditions. That's what has shut the economy down. That's what keeps us at home. That's what closes schools. That's what closes restaurants and all of that kind of stuff. That's what has such a high mortality rate through these long-term care homes. So what we really care about on this table is these last three columns: hospitalization, severe illness, and death. So 2 to 3 weeks after your first dose, about 2/3 to 3/4 of people are protected. 3 to 4 weeks, we're getting up closer to about 80%. And 1 week after the second dose, we're up around 90%, which is fantastic. Next slide. But what about allergies? So allergy rates do seem to be higher with these vaccines, but in all cases, outcomes have been good. So with a flu shot, you'd expect maybe 1 in a million people to have an anaphylactic severe allergy reaction. With these vaccines, it might be closer to 5 in a million. So it's not common. It's still very unusual. It just happened more than we expected it. But every vaccine site is prepared to manage, with epinephrine. We have a plan, and outcomes have been good because we know what to look for. The recommendation is for people who have a history of anaphylaxis. And in my vaccine clinic, what they've decided is anybody who has any allergy. So if you have a cat allergy, you're going to wait, instead of the regular 15 minutes that everybody waits, you're going to wait 30 minutes just to be safe. Next slide. So viral vector vaccines are AstraZeneca and Johnson & Johnson. So viral vector vaccines use a safe virus to carry some of the genes of the SARS-CoV-2 virus to teach the body how to recognize it. Next slide. So if we start with number 1 here, scientists make a harmless adenovirus that delivers a short genetic code to your cells, and your body destroys the adenovirus after. For number 2, the genetic code tells your cells to build the same kind of spike proteins that COVID-19 has, but this can't change your DNA. So when I'm talking about adenoviruses, what am I talking about here? So an adenovirus commonly causes colds and other mild symptoms. Certain adenoviruses were chosen for this vaccine delivery job because they are modified so they can't infect humans. So the AstraZeneca vaccine chose a chimpanzee virus that doesn't make humans sick. We don't catch colds from chimpanzees in this way. So they took this virus, none of us have it, we don't have immunity to it. They then modified it so it not only can't make you sick, but it doesn't spread in your body, it doesn't spread to other people. So they use it almost like an envelope or a briefcase with the information, kind of like the mRNA vaccines. The instructions on the spike protein are hidden inside the safe virus that's like an envelope or a briefcase that can get carried into the body. Your body can throw out that envelope or briefcase and use the instructions, and the instructions are just for the spike protein. Johnson & Johnson uses a human adenovirus that's modified in a very similar way. So your body sees the new spike proteins and starts building a defense and launches an attack. You again feel fatigue, aches, and fever at this point. It's your immune system learning. Your body can now recognize COVID-19 spike proteins and fight off COVID-19 effectively. You're immune. Next slide. So we have two viral vector vaccines. We have AstraZeneca and Johnson & Johnson. So AstraZeneca is a 2-dose vaccine, very similar to the mRNA vaccines. It's people 18 and older. And of course, there is these restrictions, and I should actually update this now. NACI is saying over the age of 55 only. I'll get to that with the side effects in a couple of slides. For Johnson & Johnson, it's a 1-dose vaccine. This is the only vaccine that is a single-dose vaccine, which is really the only COVID vaccine. So this is one that we're really looking at. It makes things a lot simpler for getting people vaccinated. Next slide. So how effective are they? This is the big question for a lot of people. They don't want the less effective vaccine. So what do we mean when we talk about effectiveness? So with the AstraZeneca and Johnson & Johnson vaccines, there's around a 60 to 70% protection against any illness. So that means that about 2/3 to 3/4 of people who get this vaccine, if they were exposed to COVID, wouldn't have any symptoms whatsoever. They likely would be protected from testing positive, no symptoms, anything like that. About a third to a quarter, or a quarter to a third, might have mild cold symptoms. So with the mRNA vaccines, that was about 5%. With these ones, it's about a third to a quarter. But again, mild cold symptoms that's not the problem in the pandemic. The problem is severe illness, hospitalization, and death. These two vaccines are extremely effective at protecting you against the things that make this a pandemic: severe illness, hospitalization, and death. And that's why they say we should absolutely be using these vaccines in people, the first one that you can get in a third wave with variants that are spreading like crazy. It's not a choice between, should I wait to get the mRNA vaccine? It's, if I could get vaccinated today with this vaccine, I should take the first vaccine I can get rather than wait 2 weeks unvaccinated in a third wave with very contagious variants. And so it's trying to shift this conversation from choices between vaccines to actually, what is the fastest vaccine that I can access in this pandemic? Next slide. So there's an interesting preprint that came out of Scotland, where they've had a lot of people vaccinated. The UK has done a great job getting people vaccinated, looking at about 5 million people and how effective was a single dose of Pfizer or AstraZeneca in folks who were vaccinated there. So the effectiveness appeared to peak at around 4 to 5 weeks, and this is specifically for hospitalization. The highest effectiveness after one dose for Pfizer was 85%, and AstraZeneca was 94%. So again, even after one dose, we're seeing very good protection against hospitalization. And the ones we care about, severe illness, hospitalization, and death, are front of mind. Next slide. So who should not get one of these vaccines? So if you have a previously confirmed allergy to one of these vaccines, so you have your first dose and it's Pfizer or Moderna or AstraZeneca, and you have a bad allergy, we wouldn't give you a second dose of that vaccine. You may be in the future able to have a different vaccine, though, a different one of the options. Also, if you have an allergy to one of the components, so polyethylene glycol and polysorbate are the ones we look at mostly for the mRNA vaccines, it'd be very, very unusual for people to have known allergies, not suspected, but if you have a known allergy to one of the ingredients, what that would mean is we might say, okay, well, don't take that vaccine. This other vaccine, this other COVID vaccine doesn't have those ingredients. Let's do that one instead. So the other three are more about making sure we have good, robust responses to the vaccines. So if you have symptoms of confirmed or suspected SARS-CoV-2 infection or COVID, we would wait until you feel better, just so that your immune system is ready for the vaccine. If you're acutely ill, so you have a fever, you have an infection on antibiotics, things like that, we wait until you're feeling better so that, again, your immune system is ready for the vaccine. And if you've had another vaccine in the last 2 weeks, usually it's the pneumonia vaccine or the Shingrix vaccine, we wait 2 weeks after you've had the last vaccine before we give this one. Next slide. So what should I remember from the side effects of these vaccines? Well, 8 in 10 people complain of a sore arm, but only 1 in 100 call that soreness severe. This is very similar to the shingles vaccine and to the tetanus vaccines. They actually very similar side effects to that. 5 in 10 people complain of fatigue and headache, but only 1 in 10 need Advil or Tylenol to manage that. And the side effects are the result of an expected immune response to the vaccine. Most are mild and easily managed at home. Next slide. So Thrombosis Canada has some good information on the AstraZeneca side effect. What has put AstraZeneca in the headlines? This question about this rare and unusual clotting disorder. So what Thrombosis Canada, these are the blood clot experts in Canada, what they say is keep in mind that COVID-19 has killed over 15,000 Canadians so far, that about 1 in 100 Canadians who get COVID end up needing intensive care, and that 1 in 5 Canadians who are hospitalized with COVID-19 develop blood clots. Currently, Canada is experiencing a third wave of COVID-19. These vaccine-induced blood clots, if it is being caused by the vaccine, we're not totally clear it is, but if it is in fact tied to the vaccine, it's very rare. While the AstraZeneca vaccine has proven effective at reducing severe illness from COVID. And again, COVID causes clots. Healthcare professionals, scientists, and government agencies in Ontario and around the world will continue to monitor the safety of this and all vaccines. And so we have to remember, for example, one of the earliest presenting symptoms early in the pandemic for young people with COVID was strokes. COVID causes blood clots. And actually what makes COVID so hard to manage is blood clots. So we're trying to keep this rare and unusual side effect that's emerging, seems to be in younger people, maybe women. That might be because healthcare workers tend to be younger women. We're not really sure. And they got the vaccine early. That's why they're now saying, let's just hold off and give this vaccine, AstraZeneca, to people 55 and older. We just saw the list announced today for pharmacies that are going to get AstraZeneca this week. That was just released now. Lots of pharmacies out there really trying to get people the first vaccine they can get in the beginning of this third wave, especially it'll be people over the age of 55 as we investigate and look more into this potential rare side effect, rare but unusual side effect. Next slide. So as your immune system learns from the COVID vaccines, any of them, you might feel fatigue, headache, achy muscles, chills, no low fever, feeling slightly bad for a short time as you build immunity for a long time. Next slide. So common questions that were asked that I'd say for all the vaccines is, were these developed too fast? It feels like it was too fast and I don't know if it's safe. So the thing that you need to know is that vaccine research is slow, not because it needs to be slow, but because we don't fund it. We have not put money into it. And actually researchers who were trying to find vaccines against SARS and MERS had said, you know, right after those early concerns, the outbreaks where we were really concerned, we tried to do research, we created vaccines, and we couldn't get money to run trials. And so they'd wait years between phases of trials. No one was interested in funding it until we ended up in a global pandemic that shut down almost the entire world. Countries, companies all came forward and put incredible resources towards finding vaccines. So what this shows us is if we funded science like this, we can actually get solutions, cures, vaccines extremely quickly, but it takes a very concerted, coordinated effort. That's what the speed was about. It's actually about funding things well and efficiently, rather than, you know, researchers begging for money to get through phases of research. We've talked about how the vaccines can't change your DNA. We've also talked about the ingredients. The things to know about all the vaccines approved is they're generally considered to be preservative free. They don't have a lot of extra ingredients in them. The mRNA vaccines we preserve by freezing at really cold temperatures, for example. There are no blood products, no fetal cells, no pork products, no animal products or anything in any of these vaccines. And the last question I get that applies to both is, what kind of long-term data do we still need? People think, well, I don't want to get this because I'm worried that some long-term side effects going to come out. That's not really how vaccine side effects work. So you tend to have your side effects, your usual ones, show up, a day or two after your vaccine: sore arm, tired, fatigued, headache, that kind of stuff. We know that, so we watch for that. Rarely, after a viral infection or a vaccine, you might get some rare neurologic things like Guillain-Barré. With flu shots, for example, the flu causes Guillain-Barré in 10 per million people, but the vaccine causes it in 1 per million people. So it's safer with the vaccine, but it could still happen as a side effect. Those kinds of side effects tend to show up about 6 weeks at most after a vaccine. So when we think long-term side effects, we think 6 weeks after a vaccine. After that, it doesn't tend to be associated with the vaccine. What we actually want from a long-term research standpoint is effectiveness data. We want to know how long one dose protects you. How long do 2 doses protect you? How good are these vaccines at protecting against variants? Do we need to have a booster in 1 year? Do we need a booster in 5 years, for example? Another big question is, if you get AstraZeneca now, there's studies underway to say, can we give you Pfizer or Moderna later? So can we mix and match vaccines? Is that even better maybe than just one vaccine, one type? So those are the kinds of long-term questions that we're looking at. We also want to know if it protects you against being contagious. Next slide. All the same kinds of questions get asked for the AstraZeneca and Johnson & Johnson. The effectiveness is the big one. And as I've just said, these vaccines are all extremely effective for severe illness, hospitalization, and death. Just like with mRNA vaccines, we're waiting for long-term effectiveness data. The mix and match questions coming up a lot. The vaccine doesn't have doesn't have blood products, doesn't have animal products, doesn't have fetal tissues. All of this is the same. So these are all excellent, excellent vaccines. Next slide. So we also need to build vaccine confidence. We need to build it, for some of us, we need to build it in ourselves. Some of us need to build it in our families. Some of us need to build it with our patients. So how do we do that? Next slide. So first, it's recognizing that concerns and denial are natural and normal. Denial doesn't stem from ignorance. Often it's anxiety. People are, there's something, you know, they just don't know if they're making the right decision, and they need support to feel confident in the decision that they're making. Next slide. So we have people who will take, you know, they'll accept the first vaccine they're offered. People will have some questions, and people who will hesitate for one reason or another. Things that hold people back are, you know, they're not sure it works, but like I've said, these vaccines are really wonderfully effective. Vaccine safety and rare side effects. And so we're watching things like this AstraZeneca thing closely and weighing the risks and the benefits. This is the system working. We want to be seeing any of these unusual things coming up and then be able to investigate them really significantly to know that it is a concern or it's not a concern. But the other one that's a real problem right now is people have made it a year. Many people have made it a year without being infected, and they feel like they're not at risk, but the game has changed with the variants. And so people are coming into hospital. And one thing that we hear from a lot of people, like the, people who are intubating people in hospitals, are saying, how could I have gotten COVID now after a whole year? I have no idea. So we have to remember that these vaccines are effective and they're safe. We are all still at risk until this is done, and vaccines are the way out. Next slide. And just looking at survey research, when the vaccines were just an idea, a thing that we needed back in July, only about half of Canadians said they'd get it when they're offered it. In the fall, that dropped to about 40%. But as we started to get news about the Pfizer vaccine and then the Moderna vaccine and the AstraZeneca vaccine, you can see confidence in the vaccines has risen quite a bit. And we expect this to keep going up. So we're hoping the majority of Canadians will get this when they're offered it. And then we need to spend some time with those who still have some questions and are hesitating for one reason or another. Next slide. So if you got the vaccine, be proud and make it public. People are more likely to get vaccines if their healthcare providers also got it. One thing I'm noting when I'm in the vaccine clinic vaccinating people is that we have people coming in, older people saying, you know, my adult son or my adult daughter told me, don't get the vaccine. It's not safe. And I can't live like this anymore. So I got my sister to drive me, or I called a taxi because I want it. We have to look to everybody who's gotten the vaccine to build confidence in those who follow behind them. So if you get it, be proud and talk about it. Next slide. And this is just the last slide that I'll end on. It's a busy one, but it's just to show you, these are all the vaccines that are being researched around the world, that are being used. We've got the mRNA vaccines, the viral vectors that I've talked about, protein subunit vaccines, which I didn't even talk about, but that's the Novavax vaccine they're looking at making in Montreal. We've got the old-fashioned inactivated virus vaccines from China, the CoronaVac and the BBIBP. So there's so much research going on in this. I suspect we'll see a lot of news. This will continue to dominate the headlines for many months to come. Thank you very much.
Thank you, Dr. Grindrod. So much valuable information there for us to take in. While we transition to Dr. Nicole Didyk, I'd like to invite our participants to go ahead and place your questions in the Q&A box, and we'll address them at the end of the session. Okay, over to you, Nicole.
Muted. There we go. Thanks so much, Don, and thanks, Dr. Grindrod. That was an excellent review, and many of the points that I was planning to cover, you've covered beautifully. So, so this shouldn't take too much time. But what I wanted to sort of give you a perspective of is my work with older adults. Being a geriatrician, you know, most of my patients are in an older age group, and I'm getting a lot of questions about vaccines from older adults and their families. So many of them, Dr. Grindrod did touch on, but there's a few others that I think it's worth looking at. So we can go to the next slide. So the questions that I'm seeing are, yes, which vaccine should I choose? Do they actually work in older people? Should I be afraid of side effects? What about my older family member? So a lot, you know, I'm even getting questions like, my dad's 90, he's very immobile, and I'm afraid that if he has to spend a couple of days in bed with a vaccine hangover, that's just going to be a setback. So should we go ahead? The other side of the coin is that people are concerned that if they don't get side effects after a vaccine, it means it's not working, and perhaps they should get an antibody test to see if they're immune. And although in my experience, a lot of older adults are embracing vaccination, they continue to have anxiety about when it's time to go out afterwards. So when can the person consider that they're immunized? And as Dr. Grindrod mentioned, after a year of sort of staying in and using very careful precautions, is it really safe to go out even if a person is vaccinated? So we can touch on some of that today. So again, and Dr. Grindrod covered some of this, but really the main vaccines that I've kind of done a bit of a deep dive in are these 4 that are currently available in Canada. And they have different benefits to them. I mean, obviously, the AstraZeneca and the Johnson & Johnson Janssen vaccine are attractive because they don't require freezing, and also financially, you know, they can be much less costly than the Pfizer and the Moderna vaccine. So from a global perspective, those are some very positive things. A lot of people have asked me if the Johnson & Johnson vaccine would be better for older adults because it's only one vaccination, and that may well be an advantage for some older adults. Dr. Grindrod covered this really well. Her slides had little happy faces on them, mine don't, but essentially the mRNA vaccine this is how it basically works. You cannot get COVID from the vaccine and it cannot change your DNA. Those are 2 messages that we do find ourselves repeating to reassure people. And then next slide shows how the adenovirus vaccines work essentially. So it's really exciting to see how the genetic engineering has been so instrumental in developing these vaccines. So again, these slides don't have happy faces, but they're you know, they just kind of illustrate how the vaccines work. So they do not, you know, you won't turn into a chimp, you won't change your DNA. They're very safe. But let's look at how they work in older adults. And the data, unfortunately, there were not a whole lot of older adults in the initial studies with Pfizer and Moderna. Overall, the number of adults over the age of 75 was about 4%. Who participated in the clinical trials. So looking at that data, it was actually difficult to say what the efficacy was from that. There just weren't enough participants and there weren't enough people getting COVID, truthfully, to give us some meaningful result from the clinical trials. Although there's very good data up to the age of 75, I would say, for very good efficacy. Similarly, in some of the adenovirus trials, there were a low number of participants. A little bit more in the Johnson & Johnson, where 35% of participants were over 65, but still a small percentage of that over 75 group. So there were some gaps, I would say, in the sort of clinical trial data. But if we look at the next slide, what I think is valuable, and I think what Dr. Grindrod was able to show us as well, is that if we look at the real world vaccine experience, there is some very encouraging data for the older adults. So I need to correct my slide because we've delivered 5.5 million vaccines here in Canada. Those in long-term care, about 90% are vaccinated, and we have seen a reduction in mortality even between the first and second wave, as some of our older adults were vaccinated very early. So that's exciting. Similarly, in the US, long-term care deaths have really gone down by 89% compared to the 58% reduction in the rest of the population. So, you know, and then we're getting, as Dr. Grindrod showed, sort of those real world efficacy rates in countries that have had their population vaccinated for a longer time. So I think we can tell people that although there was a bit of a gap in the clinical trial data for those over 80, the real world experience is definitely showing us that the vaccines are valuable. So, you know, I think we should encourage them. And it's worth remembering, you know, COVID is not, as some people have said, it's like a death sentence. If you get it, you know, you're going to die, or my mom's going to die if she gets COVID. So that's, you know, we don't want people to get COVID, but most people do recover from it. So even in older adults, if we look at those over 80, it was hard to actually tease out the mortality data, but certainly we know it is much more fatal generally in older adults. So older adults represent 6.7% of COVID cases, but over 2/3 of the COVID deaths. So mortality is higher, but it's not a death sentence. If we look at the US data, overall mortality is high. It's 16%. But, you know, that means 86% almost of people recover. And it is much lower as we get below 80. So, you know, COVID, and even if you, and this is just mortality, so even if people get COVID, they could be left, if they recover, they could be left with significant changes to their functional capacity and their wellness. So if we look at the risk of the vaccine and side effects, which I'll briefly touch on as well, versus the risk of illness, getting COVID, the vaccine definitely benefit outweighs the risk. As Dr. Grindrod said, most reactions are mild and local, but they're less likely to happen in older adults. So if you kind of, again, looking at the clinical trial data, older adults were less likely to have local or systemic reactions. So, you know, and that's probably relates to immune senescence and how the immune system changes as people age. But those who are worried about vaccination because they think that their older relative is going to be in bed for a few days, you know, most likely that's not going to happen. And certainly that's been my experience, is that my patients who've been vaccinated are tolerating them very well. We can go to the next slide. You know, which vaccine should you choose? I think, as Dr. Grindrod said, I mean, whichever one you can get. I really discourage waiting for the perfect vaccine. I think if you're offered a vaccine, it should be taken. I think we do have good real world evidence and hopefully building peer-reviewed evidence that the vaccines are effective in older adults. We shouldn't be afraid of side effects. You know, most likely they will be mild and the risk of getting ill with COVID is much higher. Do the side effects mean it's not working? Not necessarily. I mean, I think people have really gotten the message that the side effects mean your body's working. So many people who've had mild or no side effects are telling me that it's not working. That may not be true. You know, certainly efficacy is likely to be lower in older adults, but not having side effects doesn't mean your vaccine was useless. And you don't need an antibody test. This might be more common in the US, where you can order an antibody test online. And for $600, you can see if you have COVID antibodies. Those tests, you know, from what I've read in the literature, they're not really designed to see if your vaccine works. So they're mostly designed to see if a person has had COVID, COVID illness. So doing an antibody test and saying it didn't work, and if it's negative and saying that you need another vaccine, I would not go down that road at all. So if somebody asks you if they need an antibody test, I would say no. I think the most difficult question to answer is when can we consider ourselves vaccinated? When can we see our grandkids again? When can we, you know, go back into life? And this is a really important question because, you know, there's such a balance between being safe from COVID and being safe in other aspects of our lives in terms of our social interaction, physical activity, and well-being. And so my advice is to be sensible and to continue with infection control practices, such as washing our hands, staying home if you're sick, wearing a mask if you're sick, following sort of the public health precautions. But it might be a good time for people to think about the different risks that they're experiencing from being isolated, and having a vaccine, I hope, will give people more confidence to feel like that that risk and balance is shifting more towards being able to have more freedom. I really think vaccination is the way out. I think it's so exciting that we have that available. And I'm definitely encouraging and celebrating all of my patients and family members who are getting vaccinated. So I'll probably just leave it there. There's certainly a lot more we can talk about, but I'm very happy to answer any questions that that come up later. Thanks.
Thanks so much, Nicole, and really appreciate those final comments about, keeping up with the safe practices we've all learned and mastered over the last year. Even if we have the vaccine, it's no time to let up on that. So thank you very much for your thoughtful presentation. We'll now move on. Oh, sorry. We'll move on to Fawzia from the region of Waterloo. So welcome, Fawzia. Take it away.
Thank you. So I just wanted to share a little bit about what are the communication options we've developed at the region of Waterloo to share. Don, can you just move on to the next slide? Perfect. So there's a lot of great information and up-to-date information available for service providers. We have a weekly communication update that's live every Friday at 11:30 on our YouTube page. And there we have Chair Redmond and Deputy Hilton providing an update as to what's happening with vaccine rollout. There's also a vaccine rollout task force page on our website. We have our call center that's available 24/7, a number of media updates that come out weekly, and a communications toolkit. Next slide. If you go on to our COVID-19 vaccine information page, here you will find a number of resources that are available. There's also an option at the very top to translate any of the information on our website into a number of different languages. And so here there's connections to information in terms of COVID-19, vaccine information, the vaccine distribution task force page that I mentioned, and a lot of other up-to-date information is here. Next slide. So this is the communications toolkit, and we really put this together to support other community organizations, service providers, community leaders to help get the message around vaccines out to community members. And so the website link is there, but again, it is also linked to that vaccine information page that I showed you. Next slide. So if you visit this communications toolkit, you'll see a number of different resources that are available, including plain language information sheets. You'll see social media posts that you can use. You'll see different videos that we've developed here in our community around COVID-19 vaccine and building confidence in COVID-19 vaccine in partnership with a number of different community leaders and organizations as well. So I really recommend that people take a look through this communications toolkit and see what would be useful for them in helping to contribute in getting the vaccine confidence message out. Next slide. The one last thing I wanted to share with service providers is that public health has organized safe volunteer isolation sites. So this is a little bit different than what I was just talking about in terms of communication, but I think it is a service that we're trying to get more people to be aware of. And it's basically for those people who have COVID-19 and cannot safely isolate in their current home environment, they can self-refer to be put into a safe isolation site, which is in partnership with a local hotel. And there they will receive their meals for the day. There's someone on site all the time. There's access to other resources as well while they're there. And so this is a great resource for anyone who, for various reasons, isn't able to self-isolate at home when they are COVID positive. And if you want more information on that, I'm happy to provide that information, but you can also access it from our COVID-19 public health webpage. And that's what I have for you today.
Awesome. That's wonderful, Fawzia. Really happy to hear about that last slide and how popular that has been and effective that has been in our community. Thank you. Next, we welcome Mishi Motomura from Wellington Dufferin Guelph Public Health. Pleased to have you, Mishi. Please begin.
Thank you so much. So I just wanted to go over with all of you our process for registering for vaccine appointments. So right now, if you could just flip the back to, yeah. So right now we're accepting pre-registrations for anyone in any of the phase 1 groups and phase 2 groups. So just to go over quickly who is in our phase 1 groups. So that would include adults who are 80 years of age and older. It also includes Indigenous adults, and that includes those immediate household members. And then, of course, our long-term care home staff, our long-term care home and retirement home residents, as well as essential caregivers to those people, our adult recipients of chronic home care. And then finally, if you are a healthcare worker, pretty much any healthcare worker can pre-register for vaccine. And just to say about these phase 1 groups, you can pretty much receive a vaccine appointment very quickly if you pre-register on our website. I would say within a day or two, you should be able to book your appointment. Next slide, please. And so we're also including our phase 2 groups in our pre-registration. So anyone who is between the ages of 60 and 79 years old can pre-register. Anybody who lives or works in a congregate setting, so those would be our addiction treatment centers, any sort of congregate setting, and as well as primary caregivers for people in those settings. We also accepting people with specific health conditions, and there is quite a variety of health conditions that are included in this phase 2 group, which you can go to our website, which I'll tell you about in a second, and see who exactly qualifies under that category. And then people who are essential caregivers for those individuals with those highest risk health conditions and some of the high risk health conditions. And then finally, essential workers. And again, there's quite a large list of sectors that are included in those essential workers. So that is something you need to go to our website to take a look at. So our pre-registration website here is on this slide. You can just go to that. Go to that website, and it's pretty self-explanatory how you can pre-register. It's kind of a big button that you can click and then enter all of your information. The things to note about pre-registration is that depending on which group you're pre-registering under, that will depend on how quickly you get your booking information. So as I mentioned, if you're in one of those phase 1 groups, you should get your booking information quickly, so within a day or two. If you are in the phase 2 groups, depending on which group, you could get your booking information quickly, or it could take a month or more before you get your booking information. So just to note that. Next slide. And then if you are having any trouble pre-registering or booking your appointment, we do have a phone line, especially for people who can't pre-register online if they don't have a computer or email or cell phone, which you do need to pre-register. They can call the booking helpline, which is on this slide. And then just to let you know, we have quite a variety of vaccine clinic locations. We have 5 main clinic locations. 3 of them, sort of our mass vaccination clinics, 3 of them are in Guelph. And then we have another large one in Fergus and another large one in Orangeville. And then we have a variety of pop-up clinics in some of our outlying areas to capture some of the more remote locations. So we have them in Arthur, Shelburne, Drayton, Mountain Forest, and Palmerston. Next slide. And just finally, just so you know, we have quite a lot of information about vaccines on our website, including some of the troubleshooting you might have to go through with pre-registration or with booking your vaccination appointment. So just letting people know that you can go to our website and check out all the information there. And we do have also, which is actually quite useful, is a frequently asked question webpage, which you may want to check out. And I think that's all. So I guess.
Yeah,
open it
thank
up.
you, Mishi. Thank you, Mishi, for that. And thank you to all our presenters. I know if you want to pop your screens back on, we'll address a few of the questions that have come in from some of the participants today. And I know I have a question, and I'd love to be able to ask that of Fawzia if we're able to have time for that. So one of the questions, very easy to answer. I'm going to stop sharing my screen right now so you can have a different view of the folks with us today. One of the questions was, will the presentation be shared? Yes, the presentations deck will be shared along with the recording of the sessions following the close of the session today or early next week. One of the questions we have is, I know a lot of people are being given their second dose 4 months out. Does this mean everyone will need to get a third shot afterwards? Would it still be effective? Dr. Grindrod.
This is I think there's a few elements to this. This would be the long-term research question that I was referring to before. So one question is, can they, with the shots that we start to get in June, July, August, depending on when you got your first shot, does it have the variants covered in it? That might be one added bonus of the slightly delayed second dose. So it's not that your series restarts. Usually a delayed second dose actually is okay. You know, having a later second dose of any of the vaccines that we use, that's not a problem. You don't have to restart the vaccine process because of the booster shot later on. So one of the questions is, you know, are we able to kind of race against time and get the variants in those second shots? And we're optimistic, but we'll see.
And that ties into a second question. It is around the variants. Are the efficacy rates that you've talked about today, are they the same as those that can they be said to be as effective with the variants? Do we know that yet?
I'm not sure the same is going to be the same thing. And this is something too to know about the trials. The trials happened in different countries at different places with different variants, different rates of infection. So people like to think of these vaccines as comparing like which apple is the most delicious, but you're comparing apples to bananas, to papayas, to mangoes, and they're all very different. So all of these vaccines are effective in COVID. But the thing to note is, for example, AstraZeneca is being used a lot in the place where the British variant has been the dominant variant for quite some time, and it's working really well. It may not be as effective as we learned a few weeks back to the South African variant, but that's not the dominant variant circulating here. So the question is, for those booster shots, can we capture some of those? The longer we have spread like we have in Ontario right now, the more likely we are going to have more variants. We may see an Ontario variant emerge from this next little round of this third wave we're going through. So what we have to get is everybody vaccinated, stop the spread of this. That will end the emergence of these variants, hopefully, or dramatically reduce them. And then we might have a catch-up period later on where we have to get a booster in that covers the most important variants. So generally, yes, they cover the variants that we're going to be exposed to here. We're always going to be looking at whether we have to play catch up, though, in the next, I don't know, 2 to 5 years, probably.
Thank you. The next question moves us to the opposite end of the lifespan, and it asks a question about probably a short answer here, but some of my friends want to get pregnant in the coming months and years, but they're afraid to get vaccinated. What is your advice on that?
Yes, so the various groups on this do recommend that, you know, if you are someone at risk of getting an infection, it's better to get the vaccine than to get COVID if you're pregnant. There is the other question that we're looking at around pregnancy and vaccination is that mothers may actually, who get immunity through vaccination, can transfer some of that immunity to the babies as well. So mothers with immunity can protect newborn babies. So for all these folks, what we say at our vaccine clinic is if you're pregnant or breastfeeding, the question we ask is, have you talked to your care provider, your obstetrician, midwife, family doctor? If you have and you feel comfortable, we can vaccinate you. But we do want to make sure people they make an informed decision about that. But the recommendations generally, we believe that it's safe, but it's worth a conversation always.
We have some questions now about those who may be homebound. And what is the time frame for people who are homebound to get the vaccine? If they're unable to get to the clinic, can we talk a little bit more about the mobile teams in this session? Now, I know Dr. Sharon Ball covered that to some extent in the previous section. So if we can't provide the fullness of an answer in this session, we'll share those slides with you as well, so you can see how she captured that. Does anybody want to comment on that? Is there any key messaging for the group?
I can give a short comment on behalf of Wellington Dufferin Guelph area that we've just started deploying our EMS to go out to those people who are homebound and can't get to a vaccine clinic to give vaccines in their home.
Great.
Yeah.
Thank you, Mishi. I think the notion was that it's slow, but they're seeing as many people as they can within a day, usually 20 per day. I think it's the number I heard from the last presentation. And that was covering, I'm not sure if that was also covering the congregate settings or that was something different. So I'll leave that, but I'm happy to share the slides with you from the previous session, which I think will answer those questions. I have a question for Fawzia, and in your work as a community engagement lead in reaching out to different populations within our community, you're likely hearing about hesitancy from certain groups. Can you talk a little bit about the way the vaccine is being accepted or received from a cultural perspective and how that might inform providers?
Absolutely. I think every community has some myths, I think, that are more prevalent than in other communities. So when we're looking at vaccine hesitancy, it really is about which community you're talking about and who you're talking with. And so it's finding out that information through engagement with community leaders, and it doesn't have to be formal community leaders, but even informal community leaders who really know what's happening on the ground, and then working to kind of demystify some of that information. What I'm hearing is there's a lot of information out on YouTube and WhatsApp, and it's trying to find information to counter those myths. A lot of it has to do, with some of the products that are in the vaccines, where the vaccine started. Is a lot of the stuff that Kelly has touched on in terms of how can a vaccine be developed so quickly, and then to the range of just mistrust of systems and governments, right? And so that is a bigger conversation, and more work needs to be done to build trust with these communities. But I think one of the biggest things is to not overlook the impact of people's past experience with healthcare and medication when you're offering them additional support in this way. So that really impacts people's choices, and having conversations about previous experiences and why this one is different, I think, is important. It's not something that can be resolved, I think, in one or two conversations, but the willingness to look at it from more than just the science. It's also a values piece, an experience piece, and engaging as much as you can in, what are the fears really rooted in, I think is really important. And that's what I'm hearing.
Yeah, that's great. Thank you. And thank you. One final question, if we may, and this is a question. The CDC has put forth recommendations that those individuals who are fully vaccinated are able to gather indoors with others who are fully vaccinated without the need for wearing masks or physical distancing. What are your thoughts on these recommendations being implemented in Canada?
Dr. Didyk, did you want to take that, given it's mostly your patients?
I think that's not unreasonable. I mean, I think I wouldn't judge anyone who did not feel comfortable doing that, but I think that's the best case scenario, right, is that we're all fully vaccinated. I think we still need to be sensible and use hand hygiene, and the people amongst us who double dip in the chip dip, maybe they need to stop doing that. But I think that's not an unreasonable thing to do. I think, I guess that's the answer. I think it's not unreasonable. Eventually we have to get back to some type of a thing where we are getting, balancing some of the risks of COVID with the other risks that come from us not connecting with each other. So I'm really hopeful to when we can all do that.
Thank you, Nicole. Any final comments on that?
Dawn, I just wanted to point out, you had asked about the Homebound Clinics in Waterloo region.
Yes.
On our website, on the pre-registration page for vaccine, there is a section on the bottom for mobile clinic for homebound residents. Okay. And there's an email address that someone in that situation could send an email address out, fill out an email form and send it out for homebound vaccination.
That's very helpful, Fawzia. Thank you very much. I know we are now out of time, but I would like to thank all of the folks who have joined us for today's session. As I mentioned in the beginning, it was the first of our knowledge exchange sessions that we'll offer in the knowledge exchange series throughout the coming year. Great thanks to our guests today, Dr. Kelly Grindrod, Dr. Nicole Didyk, Mishi Motomura, and Fawzia Bag, and special thanks to my colleague, Giselle Loyola, who's helped with the background preparations for this webinar. So we wish you all well. You'll receive a thank you email, which includes an evaluation short survey of today's session, and expect to receive the presentation slides and recordings next week. Wishing you all a very happy Easter should you choose to celebrate, and a very nice long weekend. Thank you again. Take good care.